All right, good afternoon, everyone. My clock just struck 2:30, so we'll get started. My name is Jason Curran. I'm with the Interior Center. I work with Interior Health as well as have connections with the Rural Coordination Center of BC. I'm pleased to help host this afternoon session. This is session 2C in public health, so a nice variety of different topics. I will remind presenters that there is a 15-minute time limit that includes questions. I'll send you a quick note in the chat, and then maybe with about a minute to go or something, I'll just remind you verbally. Certainly, anyone that's participating can enter questions to the presenters in the chat box, and I encourage you to get a head start to beat the rush when questions start flying. Attendees might pop in and out of this session, so not to worry. As I say, the chat can be used. You can exchange email addresses as well directly with other individuals if you need to. And we're just going to get right started. So this session runs from 2:30 to 3:30. We have 4 presentations, each 15 minutes long. And we'll get started with the first one, Christine. This is rural community responses to COVID-19 in British Columbia.
Great, thank you. I'm just going to share my screen. And if someone could give me a thumbs up that you can see it, yeah, okay, awesome. First of all, thank you all so much for being here today. We're really excited to share with you what we learned through this survey study that I'm going to talk about. I'll also apologize in advance. I'm on the squeakiest chair you've ever heard, so you might hear that in the background. My name is Christine Carthew, and I'm a research manager of a project called the Rural Evidence Review, and I'm based out of the Center for Rural Health Research at the University of British Columbia. And I'm joined today by Dr. Jude Cornelson, who is principal investigator of the Rural Evidence Review and also co-director of the Center for Rural Health Research. Did you want to say anything before we get started, Jude, or I'll just, okay, sounds good. So, just quickly before we dive into content, I'd like to wish a warm and sincere thank you to our partnering and funding organizations for this work. For the survey study in particular, we partnered with the BC Rural Health Network, so thank you to them. For the Rural Evidence Review broadly, we have partnered with the Rural Coordination Center of BC, and RCCBC actually co-funds the project as well. And thank you to the BC Support Unit who co-funds the Rural Evidence Review project. The learning objectives that we've laid out for today's session include first, to describe the project's approach to rural patient and community engagement in British Columbia. We're then going to share with you what we've learned through our survey study to explore rural patient and rural community experiences of COVID-19 and how they've responded to the pandemic. And finally, we'll propose a next step for this work. To give you a little bit of background, the Rural Evidence Review project is, like I mentioned, a collaboration between the Center for Rural Health Research and the Rural Coordination Center of British Columbia. And we have funding under Canada's strategy for patient-oriented research. So we're a patient-oriented research project, and this funding is delivered through the BC Support Unit. And the overarching goal of the project is to work together with rural patients and rural communities to produce and provide high quality and useful evidence for rural healthcare planning in BC. And to do this, we have 3 main activities. First, we ask patients across British Columbia what their priorities for healthcare are. We then review the international literature on these priorities to understand what other research teams and other jurisdictions have learned and done in this area. And then we bring forward what we've learned to policy and planning discussions in the province, but we're also very careful and make sure to bring the evidence back to the rural communities that we have engaged. So as a patient-oriented research project, the project is built on regular and reciprocal engagement with rural patients and rural communities across British Columbia. And one critical component of this patient engagement work is our Rural Citizen Advisory Committee. So we have a Rural Citizen Advisory Committee, which brings together rural patients from across British Columbia to support the Rural Evidence Review Project to understand as well as to action their rural healthcare priorities through research. And this committee was actually instrumental in conceptualizing the COVID-19 survey study, which we're going to dive into in just a second. It was actually during committee meetings in March, which, as I'm sure you'll all recall, is right when lockdown took effect, that we started to hear from members about their experiences of COVID-19. And members actually identified a gap in the available information and knowledge at the time. And this was the experiences of other rural communities in the face of the pandemic and how other communities are responding, with particular interest in stories of strength and resilience and innovation. So to address this knowledge gap, we launched an online survey in partnership with the BC Rural Health Network to learn from rural patients in rural communities across BC about their experiences of the pandemic and how they've responded to the pandemic. And as a note for those who aren't familiar, the BC Rural Health Network is a provincial network of healthcare advocates across British Columbia, and they have the goal to support and promote a healthcare system that improves the health and well-being of rural patients in rural communities across BC. And this survey was live, or was available, between April 17th and June 23rd of this year. And June 23rd actually marks the transition for BC from phase 2 to phase 3 of the Restart Plan. The survey was shared to rural practice subsidiary agreement communities, which I can explain what those are in the Q&A if you're curious, through local newspapers and radio stations, community-specific Facebook groups, local elected council, and local chambers of commerce. And in total, we heard from 562 patients across 144 rural communities in British Columbia. And I will note that we had significantly more female respondents, making up 79% of total respondents. And the median age of respondents was 57.5 years. And this is in comparison to a median age of 41 for the province. And I'll just note that the median in this case refers to the middle value of a data set. The household income mode was $40,000 to $59,999, where the mode refers to the most frequent response. And I'll also note that we did not specifically disaggregate Indigenous from non-Indigenous responses, although we suspect that we did have responses from Indigenous communities. So what did we find? Participants told us about physical, emotional, social, and financial consequences and effects of the pandemic. And they also told us about different local activities and programs and innovations that have emerged at a local level to support their communities and to boost community spirits in the face of the pandemic. So I'll start with physical and recreational. Participants described changes to their physical and recreational opportunities and behaviors in response to the pandemic and the associated public health protocols. As an example, some participants were unhappy about the closure of local parks and local recreational areas. While participants described increased opportunities for physical activity, including walking and virtual fitness offerings. And I'll also note that respondents perceived that living rurally during the pandemic actually allowed them to get outside more. And this is because of lower population densities, greater access to nature, and homes that are well spaced with private yards. Respondents expressed fear, stress, and frustration in response to the threat of the virus, and also described feeling lonely and isolated as a result of pandemic protocols, in particular social distancing. And in fact, the feelings of fear and frustration were heightened by the financial implications of the pandemic, which I'll talk about in just a second, as well as continued travel to the rural communities by non-residents, whether for tourism or to visit their vacation properties. And this is despite recommendations and in some instances pleas to avoid non-essential travel. And I'll just say that non-residents were perceived to threaten the capacity of local supply chains, as well as the capacity of health services to respond to the pandemic. Respondents regretted the cancellation of local social and cultural events and celebrations because these events and these activities contribute to social cohesion, they generate income, and are otherwise critical elements of residents' and entire communities' cultures. Nonetheless, a majority of respondents explained that the pandemic actually led to a coming together of their communities through alternate means to boost morale and to support one another. And then in terms of impacts, we have finally financial implications. And participants emphasize the financial consequences of the pandemic, both current and anticipated. So what's happening now and what's to come. And this included the closure of small businesses, the loss of tourism, and loss of other employment. And we actually heard from participants, or more than 47% of participants reported a minor to major impact of the pandemic on their abilities to meet financial obligations. And this percentage was actually much higher for those aged 41 years and younger, with 58% of participants in that age category reporting a minor to major impact. And then in terms of responses, like I mentioned, we heard many responses from the various respondents to the survey, and they're really fantastic. They're inspiring, actually, and I'll just touch on a couple of them today, but if you're curious to hear about everything we heard about, we're of course happy to share that at a later time. Some of these responses included adopt a neighbor and senior watch programs to check in and offer support to neighbors and those at risk. We heard about vehicle, like drive-by parades to celebrate birthdays and graduations and to lift spirits and to show appreciation for different groups in the community, including essential workers. We heard about cheering and howling at set times to show appreciation for essential workers. Local groups started to make masks, which were often sold at for donation or by donation, or were given away for free. We also heard about local breweries and distilleries shifting their productions to produce hand sanitizer, which was again often distributed free of charge. We heard about expanded food bank services, including more food bank days, and increased volunteering and increased donations to food banks. We heard about virtual readings by the library, the local library, and many more, but I'm sure we're running out of time, so I'm gonna shift it over now to Jude, who's gonna tell us about a vision for next steps for this work.
Yeah, thank you, Christine. And I'll just be really brief. So, of course, the information that we got was intrinsically interesting. We were curious to hear about how rural communities were faring. But if you look at it through a research lens, we had no baseline. We didn't know how to compare, for example, to urban centers, because we didn't focus on urban experiences. And there might be a lot of crossover. I suspect there are. But one of the things that we were very interested in doing with the wealth of information was trying to start looking at qualities of resilience in rural communities and how communities exhibited that from the ground up. And I don't mean by health system resilience, but community social cohesion resilience in the face of things like pandemics, health pandemics. So what we would like to do now is take a step with this data, merge it with some of the best practices data that we have on existing literature from pandemics. A little bit is starting to emerge specifically about COVID-19, but there is quite a bit of data on response to pandemics. And we want to work with citizen patients in communities to develop markers of resilience. And this would be metrics that come from the ground up in order to assess where a community might sit from the community participants' perspectives, mostly to be instructive in the sense of helping communities grow areas where they might want to grow. So Christine, just the next slide. So what's really clear, of course, is that there's, and we heard that there's different, for example, response to what resilience means in Indigenous and non-Indigenous communities, and other characteristics that make it really important for us to look at these two groups. So we're really interested and have started the discussions to work with First Nations Health Authority, as well as citizen patient groups across the province in order to start discussions about what these metrics of resilience might look like. So we can basically assess how people, or communities, I should say, can assess how they're doing with response to COVID, but also so we can share it with other jurisdictions. So that's all I'll say now. Jason, I'm not sure if we actually have time for any questions, but we're happy to take them.
Yeah, I think we could probably slip a question in there if anyone has it. As well as I'm sure you can in the chat box message both Christine and Jude directly with your question as well. Maybe what we'll do is, oh, go ahead. Do I hear a question?
No, I was going to say, no, it's Jude. I was just going to say we'd be super stoked to talk to anybody who's interested in issues of community resilience.
Brilliant. Thanks, Christine. Thanks, Jude. That was a great presentation. We're going to jump to our next one. What is missing from patient-oriented research? A view from public health systems and services research.
Thank you. I'm just going to share my screen. Okay. Can everyone see the full screen rather than the presentation version? Okay. Great. Thank you so much for having me. My name is Sana Stram, and I'm joining you from the ancestral, traditional, and unceded territory of the Silk Nation. And I'm here to talk today a little bit about what's missing from patient-oriented research. How might we sort of expand on this idea with a specific focus on looking at how public health thinking and public health systems and services research might help us to think through doing this work differently and more thoughtfully in the future. So before we sort of dive into some of those ideas, I think it's really important to always think through what is the aim of these two different things and what do they have to gain from each other. So if we think about SPORE, or patient-oriented research, the main aim is to empower patients in a process of research that makes research more responsive and responsible to the needs of the public. And ultimately, the goal is to improve healthcare services. If we think instead about public health systems and services research, the focus is more specifically around understanding how systems work and identifying ways in which they can be improved in order to promote better health and reduce health inequities. And so the question becomes, when we're thinking about these different definitions and why am I being nitpicky about them, is thinking through what are we talking about, especially when we're talking about patient-oriented research. Are we talking about better healthcare or better health? And you might be asking, what does that matter? Aren't they the same thing? But if we think about where we're at in 2020, we're at a really interesting time where we're seeing sort of a convergence of three major public health emergencies. So the COVID-19 pandemic, the overdose emergency in BC, and the ongoing but heightened emergency of systemic racism with global anti-racism protests. And what we're seeing at this time is we're really drawing attention to the fact that there's a really urgent need for deep structural shifts in the way that we deliver services and create public systems. And it's really drawing attention to the fact that there's persistent and continued inequities experienced by people who are at the intersection of different structural inequities. So when we're looking at, if you look at the graph on the top left there, it didn't actually show very well. That red band on the bottom is actually showing overdose deaths by month in comparison to the blue band, which is showing COVID-19 deaths by month. So not to braid the point, but if we think about the different people who are largely impacted by those emergencies and the different funding and coverage and response that these things have gotten, I think it becomes really clear that thinking through issues of power and privilege are really important. And especially when we're looking at, for example, even the impact of COVID-19, we see that all of these public health crises actually just recreate and exacerbate all the inequities that are persistent in our social structures. So they bring them to light. They don't create them. So they're not the cause of them. What's the cause of them is actually the way our societies are organized. The nice, I don't want to say the nice thing, the window of opportunity that has been provided by this convergence in 2020 is that it's finally given us a really powerful window to step through and start to talk about these things and really start to unpack this idea of, is what's going on for people sort of at the bottom of the social ladder? Is it just bad luck or is it inequity? And how do we know if it's an inequity? And inequities are defined by being systematic. So the differences are not distributed randomly, but they show a consistent pattern in the population. And this social pattern is universal, though its magnitude differs. And so this is exactly sort of what's happening with these convergent public health emergencies is we're seeing the same systematic patterns where regardless of the public health emergency, the people who are doing who are the worst off in these situations, the people who experience the most harm in these situations are the same in terms of social position. They're also socially produced, which means that the differences are not biological, they're created by some type of social process. So if we think about, for example, the fact that there is no law of nature that says that children who come from families that are poorer should die at higher rates than children who come from families that are richer. So that means that it's something that's going on in our society, which means that it's something that we can actually do something about. And also that they're unfair. And we could talk probably for hours and hours about what does unfair mean, but basically they offend our general notions of what is fair and what is just. So why does that matter to poor, or us, poor, or poor? I don't know how you guys like to call it, but patient-oriented research. It matters because if we're thinking about inequities, we also need to think about what does it mean when we're designing a strategy for inclusion and empowerment in processes, but we're using a word like patient. So patient is defined on SCORE to include people with personal experience of health issues, as well as their informal caregivers, family, and friends. So it's really got a few strengths there. So it's focused on people's experience as a source of knowledge, and it's also including the people involved in that person's healthcare experience. Some of its drawbacks are that it implies that a person's already sick. So it reinforces this idea that health is an individual characteristic and that it needs to be responded to through acute or chronic healthcare, which by extension may involve families. But if we think again about sort of the inequities lens and the health equity lens, we see that health is actually quite political. So health is substantially a function of the distribution of resources for healthy living. So that depends on things like class structure and ownership, discrimination, racism, sexism, colonialism, ideology and politics, and the organization of the state, and people's access to spaces where they can make decisions, and power and privilege. And so these are all dimensions of social processes, and they're also socially contested, which means that they're political. So when we talk about the patient, as opposed to communities or groups of people or populations, this is in fact ideological, and it becomes ideological because it construes human health as an individual response to internal and external factors, and it ignores the social context, which may in fact be more important for our focus if we want people to be healthy. So what can public health add to that? So if we think about where we're focused, and I'm sure many people have seen sort of this metaphor of the stream, when we're talking about patients and we're talking about healthcare, we're really focused on the people in this metaphor who have fallen down the stream, and we're trying to pull them out of the stream. So giving them better care, give them better services, and hopefully rectify whatever happened with them falling in the stream. If we think instead about expanding our focus to include public health and public health thinking, then we start to think about, well, maybe we should find a way to keep people from falling into the stream. So public health approaches specifically, they'll draw our attention to determinants that shape health, like things like power, privilege, social processes, social determinants of health, to sort of help expand what we mean about keeping people healthy. So if we think about sort of the limits of patient-oriented research and what we could do with public health is really thinking about how we break open the echo chamber. So when we're keeping our definitions pretty limited and we're requiring people to sort of ascribe to this idea of patient, they're already involved in the health system, they're already sick. And in some ways, in order to be a patient and identify as that, they have to be in some ways empowered to be involved in the system in the very first place. And that runs the risk of creating basically an echo chamber where people are possibly more likely to be approached or included to participate in SPORE projects because they tend to represent and reinforce the status quo. They might be selected as representatives because they're more socially acceptable, or they're more unlikely to threaten the existing power dynamics because we're not paying attention to sort of this broader idea of what does it mean to be included as a community. Another challenge with this is if we don't contextualize sort of the relative power and the resources and the social constraints for people to be involved in research, we essentially can lead to thinking of patients as sort of these individualized or autonomous people who can represent somehow larger groups of people. It can lead to tokenism or creating checklists where we take research systems that are already flawed, healthcare systems that are already flawed, that reinforce structures that keep people from being included in them, and then we place patients within those systems without actually changing the systems, and then we consider that to be sort of a checklist because we included some patients, and so we can go about our day. And really, this is basically driven by our preponderance to think about things sort of in a linear way. So we think about a research problem, we take data in, we come up with a solution, and we implement it. And so when we do patient-oriented research, we include somebody in that process, but we're not necessarily changing the system or the process itself. And so the argument is that if we can think more along approaches that have been endorsed by, for example, public health or community-based participatory research, or approaches that have really existed for a long time before patient-oriented research sort of became the new shiny thing for us to focus on, we can start to embrace the complexity that's going on and really think of things from more of a systems perspective. So when we think about some of the wording that we see on the SPORE website, we hear terms like patients, academic researcher, service provider, health policymaker, and there's this implication that these are somehow mutually exclusive groups. They create these binary or fixed categories that don't really capture what's really going on in a system. It plops people sort of into places, everyone plays their role in a predefined sort of structure, and then we go about our day. So what does that mean? Why is it a problem? Just one quick example. CIHR. So CIHR right now, we're going through the process of applying for a project grant, and many of the people on the call or Zoom today will be familiar with the fact that when you apply for a CIHR grant, you have to, it's mandatory, and it's been mandatory, I think, for almost 10 years, you have to say how you're taking sex and gender considerations up in your research. You also, this year, I had to do a mandatory 45-minute training on sex and gender considerations. And on the left there, this is CIHR's own course, which is talking about why sex and gender matter in research. On the right is the form that you have to fill out to participate in an application to CIHR. And you'll notice that it's a required field, it's binary, and it doesn't at all take sex and gender considerations into consideration. So on one hand, we have this wonderful strategy that's been taken up. Sex and gender analysis is super important, and that probably came about with really good thinking. But if we don't think about things from a systems perspective, if we don't think about every step of inclusion and empowerment, we end up with a form like this, which is actually structurally violent towards people who are gender diverse or who don't fit sort of this binary definition. So on one hand, they require us to do something. On the other hand, they themselves are violating their own preset requirements. And so this is what's usually called cognitive dissonance. And so there's just this mismatch between what we're saying and what we're doing. And we actually see that a lot in a lot of our institutions. So just as an example, what you see there is, this is the National Steering Committee for SPORE. So there's 18 members, and I'll let you take that in on your own and just start to think about and unpack, what does it mean when we're talking about a strategy that is specifically about engagement, empowerment, inclusion, respect? What does it mean when the National Steering Committee has this composition? And yet, when we come to these wonderful conferences, we have keynote speakers like Dr. Christopher Horsleaf, who's talking about Indigenous ways of knowing. A couple of years ago, Dr. Bernie Pauly was the keynote speaker, and she brought people who use drugs, and different groups and different representation are brought in to share their knowledge and to share their contribution. But where is their representation at the systems level? What does that mean? Do we want to talk about that? Do we want to unpack that? And do we want to think about how that limits the work that we're doing in a real way? And what does that say about inclusion? And what does it mean about engagement? When on one hand, we say one thing, we want something, and then on the other hand, we create structures and systems that are not conducive or cohesive with what we're saying. So when we're thinking about 2020, there's a lot that's been said about it. It's a dumpster fire. It's our path to enlightenment. And I would just argue that we really do have an opportunity to think about the fact that we have this convergence of issues. We have a window of opportunity to start talking about these issues. Do we want to leave it as a dumpster fire, or do we want to talk about it as a path to enlightenment? Do we want to keep talking nice or softening issues when we're in these spaces, or do we want to have some really open and raw conversations where we think about what is it that we're doing? How is what we're doing in conflict with what we say we want to do? And how can we make up for that? Do we want to keep using euphemisms? Do we want to keep talking about incremental progress? Or do we really want to get down and do that dirty work? And I would invite us all to think about the fact that just by virtue of being in this room and the positions that we hold, we're all coming from a position of privilege. And so how can we use that privilege? How can we lean into it to hold our own systems and our own spaces into account, and start to think about the fact that, just to be really blunt, I think everybody on this call is very aware of the criticisms that have happened with the term patient and the patient-oriented research wording. Why hasn't that wording changed? Is it really hard? I don't know. Is it? Do we want to actually do work differently? Do we want to change the words that we're saying? And how are we going to do that work together? How do we dig in and do that work? And I just want to offer as sort of a last point that some people might think this is just wording. I'm just being nitpicky. These are things that we should sort of not address because we're all working towards being better. And I wonder if we would feel the same, if we'd think it's nitpicky, if we would think that issues of inclusion, power, and privilege are less important if we were the family of Joyce, if we were the family or the people who walk into our healthcare systems every day and experience racism and stigma and harm. If we were the people watching the BC government open an inquiry into racism instead of taking action on racism, would we feel that way? And if we wouldn't, what are the actions we're going to take, and how are we going to do work differently to make the healthcare system work better for everybody? So.
Great, thanks, Anna. Wonderful presentation. I think we might have time for one question. And again, you can always ask questions directly to Sana in the chat box. All right, we'll just move along to the next presentation. This next presentation is entitled Client Engagement with iOAT Sites Before and During the COVID-19 Response. Take it away.
Hi, thank you so much. I'm just going to share my screen here, and then we'll get started. Oh, all good. Okay. So before we get started, I'd just like to acknowledge that we are currently on the unceded territory of the Squamish, Tsleil-Waututh, and Musqueam people, and that we are presenting and incredibly lucky to be able to work, live, and play here. My name is Rebecca Metcalf. I'm a PhD candidate at the School of Population and Public Health at UBC, and I'm here with Adam Easterbrook, who's a sociologist at the Center for Health Evaluation and Outcome Sciences, or CHAOS. And today we're going to be presenting to you about client engagement with iOAT, specifically during COVID, and we'll be focusing on how both researchers, clients, and sites have adapted to the challenges that COVID has presented. So just a quick lay of the land. We'll start with some background to make sure that we're all on the same page. Then we'll be talking about how we've adapted our research to the COVID context. We'll present some of our pre-COVID findings and then our during COVID findings. And then we'll touch on some limitations of our work and what our next steps are. So what is iOAT? So iOAT stands for Injectable Opioid Agonist Therapy, and it's an evidence-based treatment for dependence on opioids. Right now, there are 5 iOAT sites in the Lower Mainland. And if you're a client at an iOAT site, you would go there usually a couple times a day to receive an injection dose. But iOAT isn't just about injectables. The sites also include access to other services and resources, such as social services like housing, mental health services, and extended healthcare like dental and specialist referrals. So this project specifically is one component of a much larger project called PORTIA, which stands for the Program of Outcomes Research on Treatment with Injectables for Addiction. And the purpose of PORTIA is to get a sense of those things that are often missed in standard clinical trials. So what are client experiences, what are nurse experiences, and what's our broader understanding of what iOAT is? In that context, this project specifically, as one component of PORTIA, is focusing on client preferences for iOAT delivery, and doing that using a qualitative lens, and then taking a quantitative lens to kind of try and quantify those preferences to provide that information to decision makers. And the reason we're doing that in specifically, I think everybody here would probably agree, but we really believe that people should have healthcare that meets their needs. And that means that we need to figure out what those needs are, and then we need to find ways to adapt the system so those clients' needs can be met. And in the area of iOAT, this is particularly important. This is life-saving healthcare that often receives quite a bit of pushback just to exist at all. So then trying to get an iOAT program that's really designed to meet people where they are can be even more difficult than it is in other realms of healthcare.
Awesome. So an overarching objective of the entire portion of study is to have clients involved in all aspects of the study. So we believe, I think like everyone in this room, that those who are most influenced by our research outcomes should really have an ongoing role and voice in the study. And we wanted to give people the opportunity to be involved as much or as little as they wanted to be. So some people are involved in everything, other people kind of pick and choose what's meaningful for them, and they're involved in those parts of the study. So the advisory committee is comprised of 12 clients. We have 4 clients from the largest iOAT site and then 2 from each of the other sites. And we wanted to have at least 2 people from each site so that clients felt more comfortable. For a lot of our clients, they haven't really interacted much with researchers. So we wanted them to, have a buddy to come with so that it wasn't as overwhelming as it could have been. We developed a terms of reference with clients that really went through kind of their roles, responsibilities, membership requirements, all this sort of stuff, and kind of more technical stuff as well, just that we needed to have included. But we also had expectations for us as well. So we made it clear that they had expectations or responsibilities, and so did we, such as teaching them different methods that we were going to use and that sort of thing, so that they were fully informed and could participate to the best of their ability. We also paid participants for their time, and we met at our research office, which is in the downtown east side, and it was convenient for most of the participants. Some of them were further out, but we, of course, compensated them for transit. So the advisory committee has really 3 main roles. The first is kind of this overall arching advisory role where they give input about the entire project and how it's going. That includes results and everything as well. They also assist with specific research objectives. So for instance, going through this thing we're working on now, they go through surveys, our methods, that sort of thing. And finally, they had a role with advising regarding recruitment. So obviously they can't recruit specifically, but they would help us identify groups that maybe we're missing. So maybe when we present findings or talk about what we've done, they might say, hey, you've talked to a lot of iOAT users who are older, but you kind of need to get some of these younger ones. Sorry, Rebecca. So we've had several meetings. We had an introductory meeting where we talked about the terms of reference and so what I talked about, but I also talked with them about kind of the scope of influence we have. So I've worked with a few advisory committees, and one thing I like to do is kind of lay out what is possible and what isn't possible. So the clients feel like we are listening to them. And they know that as much as we maybe agree with what they're saying, we can only push policy so quickly, so fast, because unfortunately things do move slowly. And as researchers, we maybe can't push as hard as we would like to sometimes, or have things go as quickly as we'd like to. We've met with them to go over our interview guides, study results. We've invited them to co-present with us at UBC for presentations. We've had some fun meetings like, holiday end of year meeting. And now we're just in the process of trying to figure out, how do we meet in the future? Because again, some of the advisory committees or groups I consult with, the clients there have the resources and technology to meet virtually. But unfortunately, a lot of our clients don't have those resources. So we're trying to figure out how do we meet with them as a group during COVID. So for our study, and it's kind of like some of the other people spoke about in this group, we had a plan and it didn't quite go as we anticipated. So in December, we had an initial meeting with our advisory committee. We went through our plan. Then we had focus groups and interviews with them to get the qualitative data. And the plan was to do an iterative survey development and then implement that survey later in the year. But of course, as everyone knows, COVID happened. So what we decided was that, okay, the results we have are great, but what do we need to look at now? COVID has obviously changed the pushes and pulls that clients are experiencing. So we wanted to ask 2 kind of additional questions. How has COVID changed the needs of iOAT clients? And how have iOAT sites adapted or not to address these kind of changing needs? And we felt this was particularly important because our clients are quite vulnerable due to they have lower income, they tend to live alone, they have chronic health conditions, and we also have this ongoing opioid crisis, which has already been talked about, in this group of presentations. So we really felt they were at really high risk for really negative outcomes from COVID and making it difficult to access these clinics. So what we did is we decided we wanted to look at the ongoing process through which clients either adapt or adjust or deal with COVID. And so that meant we did several waves of interviews. So far we've done a wave of interviews at the April and May. We've done a second wave in June and July, and we're just starting our third wave of interviews with clients, as well as some nurses to kind of triangulate what clients are saying. And the hope is that we can kind of get deeper into the process of adapting to COVID.
So in order to do this work in the COVID context, we had to develop some strategies to make sure that the work was safe for us and for our clients. So we came up with 5 strategies. The first one was Zoom, which maybe doesn't sound like much of a strategy. We're on Zoom right now. But Zoom is pretty neat in that it allows people to connect via phone or internet, which was really important for us, as some of the folks we're talking to might not have the same technological resources as other people. We used on-the-spot recruitment via our outreach coordinator. So our outreach coordinator would sort of be in the area and ask people if they would be interested, that he knew were iOAT clients, and ask if they would be interested in participating in a conversation with me or Adam. Part of doing this approach meant using flexible scheduling, so we'd have 2 to 4 hour windows during which clients could reach us. And to make the process a bit smoother, for folks that had participated in our study before COVID, we were able to just get verbal consent. And we also provided honorariums to participants at a place that they would be frequenting anyway. So at the clinic that they attended, or via direct deposit or e-transfer, just to make that whole process just a bit easier. And these strategies worked really well for us. We were able to speak to all of the same people so far during wave 1 and again in wave 2, but they do take more time. So if you're thinking about some of these, that's something to keep in mind. So who did we talk to? We spoke to 31 current and past iOAT clients. About 2/5 identified as women, and the majority self-identified as white, followed by Indigenous. We had a broad range of ages from 17 to 68, but the bulk of the people we spoke to were really 45 and above. So what did we find? So before COVID, we found sort of this complex model where, while the safe drug supply was something that was leading people to access the clinic initially, that really wasn't what was keeping people in iOAT. And obviously this model really intersects with other factors like age, gender, and race and ethnicity. So we're not going to go into those right now just for the sake of time. But there were within the clinic these ongoing processes of trust, building trust, leading to relationships, and then personalized care. So just as a quick example, we spoke to one client who mentioned they were going in just as they do every day, and they had a cut on their arm. And a nurse just walked up to them and said, "Hey, why don't you come with me and we'll get you bandaged up and make sure that's all clean." And the client was saying, you know, that really made me feel good. They're paying attention not just to the service that they're providing for me, which is iOAT, but to me as a real person, as a whole person. And that really helps build trust and relationships. So what did COVID do to all of that? Well, it wasn't great. COVID, the protections that were necessary to make the clinic a safe place for COVID, to avoid COVID, meant that some of the things that were really important to people weren't there anymore. So for instance, people had said to us that common spaces were really important to them as a place where they could sort of build trust and relationships through ongoing interactions. But COVID closed those. Likewise, even accessing the clinic became difficult, going to the same place multiple times a day, especially for the folks we spoke to with chronic conditions. But it wasn't all bad. As we spoke to people a little bit later, there were some improvements that were going on to try and address these. So at the clinic, for instance, people were starting to be able to have oral medications delivered to them. Obviously, that's not the same. It would be better to have injectables delivered to them, but this was sort of a stopgap measure that was better than nothing. And clients were adapting too. For just a quick example, some clients developed sort of a buddy system to accommodate, to try and sort of deal with some of the isolation that they were experiencing and missing from the previous, from the clinic being closed in the same way. What will we be finding next? We don't know. So that's TBD.
So obviously there are several limitations with our study beyond the impact that COVID had on our work. Most of the people, well, I think all the people we spoke to were from the lower mainland. So what we've done is we've reached out to some of the other clinics, and we're in the process of going through ethics with them so we can include other people. And that's especially important because the lower mainland is kind of a unique place for this program. We've talked to predominantly older adults. So again, we're working with people who are younger, and we're working with some programs that address specifically younger people who access iOAT. And most of the people identified as white, which was obviously is not great. It's not what we were hoping for. But we were connecting with some of the indigenous groups who have iOAT programs before COVID, and it just made it really difficult to connect with. So we're trying to regroup and connect there.
So just to finish up, our next steps are, as Adam mentioned, additional interviews with clients, nurses, and youth accessing iOAT. Then we'll be working with our clients and our client advisory committee to review the results and findings, and we'll be co-creating a survey with them, and then piloting that material with clients more broadly to make sure that the survey is working for everyone. And then finally, one day we will actually conduct our survey, and we'll share those results both with clients and with policymakers and decision makers in hopes that we can help design programs that will meet clients' needs. So thanks.
Great, thanks Rebecca and Adam. That was a tremendous presentation. We'll likely, let's see if is there one question out there? And if not, we'll just roll right into the next presentation. Okay, thanks Rebecca and Adam. I really appreciate the presentation. The next presentation is entitled Appropriate Access to Healthcare for Rural and Remote Communities, a community-based toolkit for investigating legal approaches.
Hello, so I'm just going to take a second to share my screen. All right. All right, so I hope that that is connected properly. All right, so I'm gonna get started and I'll keep it brief just given the timing. So hi everyone, glad to be here presenting with you all and to have this opportunity to connect with you. And so thank you to the BC Support Unit for all the great work that you guys did towards making this conference happen. So my name is Kayla Miguez and I'm currently a third-year law student. And like Christine, who spoke earlier in the session, I work with the Center for Rural Health Research out of UBC. And the project that I'm going to discuss with you today is one that we're getting started on, and it's to create a community-based toolkit for investigating legal approaches to improve access to healthcare for rural and remote communities in BC. So just a few things that I want to point out quickly before getting started is first, this project is still a work in progress, and so we want it to continue to be guided and molded by input from patient citizens and really from anybody. So we're very open to your comments on what you hear today, and I will leave my contact information at the end of the presentation. So if there's anything that you want to discuss or anything you would want to see in this project, please reach out. And I also just wanted to quickly express before moving on that nothing about this project is meant to be adversarial in any way. Rather, we're really just trying to help improve the situation of access to healthcare for rural and remote communities by sharing information on health commitments in Canada and by hoping to help strengthen capacity of using these commitments to promote social change. So the Rural Evidence Review Project is run by the Center for Rural Health Research. So Christine had spoken about this in her presentation earlier. Just briefly, it works with rural citizen patients to gather and provide valuable evidence for rural healthcare planning in BC. And part of these efforts can be seen in the outreach survey project. So this was a project that was initiated in 2018-19, and it aimed to capture the voices of rural citizens, patients, and communities in terms of their needs, priorities, and perspectives for healthcare. And the survey is not the focal point of this presentation, so I will skim over it, but it's important because it sets the stage for why we felt the need to embark on creating a toolkit, such as the one that I am presenting on. And so because of that, I will briefly explain what the survey entailed. So it was an online survey that was sent out to rural and remote communities across the province. And it asked people to respond to a variety of questions, but importantly, we asked, and I included here, what are the most important healthcare priorities in your community and why? And so we had nearly 1,500 responses come in from over 200 communities across the province, with responses from a wide range of ages, and also people who had lived in their rural community from a very short period of time all the way to 83 years. So more information on the survey results has been posted on the internet, and I've included the link up here. Again, reach out if you would like for me to send that link your way. But really, what was important about this survey for the purpose of the toolkit is that after carefully reading through all the responses that we received, there was an overwhelming theme that came through in the voices of those who responded to the survey. And that was that communities felt that there was a lack of appropriate access to care, to healthcare in their rural and remote community in BC. And so these are just two brief quotes that came out of the survey responses from the rural communities that I found really represented this message of a lack of access to care. So the first being, we're a minimum 4 hours from the next hospital or specialized care, and there's no Greyhound or other public transit. The second one is, the closest full medical facilities are 120 miles to the west and 230 miles to the east, with road and air access very much compromised at times in the winter. So these are just really just a few of the many responses that came in conveying the same concern and reality. The issue is that Canada has made commitments towards the health of its citizens. So it is important to note that Canadians don't have a constitutional right to health. So this means that in our Constitution and in our Charter, there's no explicit recognition of a right to health. But Canada has nonetheless expressed on several different fronts an understanding of the importance of access to healthcare. And these statements still carry weight in that they reflect the importance that Canada sees in helping to promote the health of its citizens. So these are just some examples I included on the slide. First is the International Covenant on Economic, Social, and Cultural Rights. And this one's particularly interesting. It's an international treaty signed by many countries, including Canada, and it contains legal protection of many different rights with explicit mention of the right to health. And what's especially interesting for rural communities is that when you look at supporting documents that help to explain what this right to health is, the concept of accessibility is defined, and I've included that on this slide. And it's defined in that accessibility implies that medical services are within safe physical reach, including in rural areas. And then when we look domestically, so into Canadian law, we have the Canada Health Act. And while the Canada Health Act does not explicitly cover physical access to healthcare, in that it's more focused on keeping healthcare financially accessible, it still explains that the primary objective of Canadian healthcare policy is, amongst other things, to facilitate reasonable access to health services without financial or other barriers. And so while there is more to be said about what these commitments mean and what other health commitments there are, this is just a briefer to explain a couple of the sources that shape commitments towards the accessibility of our healthcare in Canada. And so what do we do about this? So if you look in the literature, you see that there are public health workers who work in rural communities on access to healthcare around the world, and they've suggested methods that they use in rural health accountability. So methods that they use to try to promote action on a country's health commitments, to get public health systems to be more responsive to rural community needs, or to ensure that health commitments are respected rurally. And while there are many methods, there are two in particular that stood out as being relevant or useful for this toolkit and for the sake of this presentation. So one that is very familiar to many of you, I'm sure, is interviewing rural citizens and documenting their realities in terms of healthcare. And for our interest, rural access to healthcare. And in doing so, highlighting gaps that then exist between a country's health commitments and the reality that citizens are living on the ground. So the outreach survey that I talked about previously is similar to this first recommended method, in that it was a way through which we gathered stories and accounts from rural and remote community members from across the province about their healthcare realities, and that we continue to do. And it's important to note how integral and helpful this method can be, in that there are instances in Canada and internationally where highlighting personal stories from patient citizens led to increasing public awareness and harnessing advocacy efforts to then, apply social pressure where needed. And another recommended method that stood out as helpful and interesting is that educating communities on their country's commitments surrounding health. And so these methods collectively are what we see as being the purpose of this toolkit. And so based on the priorities of rural community members that we gathered through our outreach survey, we're currently working on creating this community-based toolkit for investigating legal approaches to improve access to healthcare for rural and remote BC communities. The overall mission of the toolkit, and I'll read this out, is to facilitate the use of the law as a tool for social change in order to translate the communicated needs and priorities of rural patients into actionable change in policy at the community level. And so who is this toolkit for? Really anybody. So this toolkit is for rural and remote BC community members. It's for healthcare workers working rurally or in urban areas, and really anyone else interested or wanting to help advocate. And so this is why we want your input, because, and I'll explain this later, but we want this toolkit to be usable for you and helpful. And what is this toolkit for? So this toolkit is to educate rural Canadians on health commitments and other human rights that relate to or affect health. And so a lot of the work that we're doing is also, translating these commitments into language that is easier to understand. And second, it's to explore what can be done to advocate for better access to healthcare. And so really what we're looking at right now as a purpose for the toolkit is bringing attention to the reality of healthcare access in rural Canada or rural BC, sharing information on health commitments in Canada, and helping to strengthen the capacity of using these commitments to then promote the social change that would be needed. And so just a briefer on some of the proposed toolkit content that I've explained already, but continuing to highlight the reality of rural and remote BC, some more information on health rights and other pertinent human rights, important definitions. So, what is the Canada Health Act? What are these other treaties that may apply? And then some of these next steps about what it is that we can do. And so, as I said, we want your input. So as we continue to create this toolkit, we want to gather the perspectives of rural citizen patients on this toolkit and to help improve its usability and to ensure that it meets their needs and priorities. And so please, if you have any comments, feedbacks, questions, just send them my way. I'll keep my email up here, or maybe I can throw it into the chat or something. And please don't hesitate at all to reach out. So thank you.
Thanks, Kayla. Once again, a great presentation, and it's a shame that we only had 60 minutes for this entire session, because all of the presentations were terrific this afternoon. We'll conclude this session just in the interest of time. Just a reminder that the next plenary session kicks off with the final panel on patient-oriented research and health technology. and the official conference closes. I want to thank all the presenters once again for contributing to a terrific afternoon session. And just take care. Thanks very much for all your participation.